Okay. I also saw an article that our system and is similar to Italy's. So our demographics and system, not necessarily of who's getting it at this point in time, because we're saying that there's a significant amount getting it under the age of 40. But is that true as well, that our infrastructure is similar to that of Italy's?
That's correct. I would say that Italy, their healthcare structure was in a little bit of a better scenario than we were. Canadian healthcare, typically, for example, in the hospital that I work at, our hospital usually, if you look at the number of patient beds, is operating at about 105% capacity, meaning that we are always over capacity. That's the same across the province, and that's the same across the country.
So we're already operating over capacity with.
That's correct. When you go into a hospital and you see patients being treated in hallways.
Oh, really? So this is without COVID-19.
Let's say 1,000 beds in a hospital, and that would be a very large hospital.
Yeah.
We would see on average 1,050 or 1,100 patients.
Really? So this is without COVID-19. This is just
that is correct. That is kind of the default state that Canadian healthcare operates at. And so when I compare that to Italy, Italy is a little bit better, where they're not quite at capacity, but they're up there. They're in that 92 to 96% range for capacity.
I think that's a very important thing for people to know, that we are already at capacity, just normally operating without COVID-19. And now you add this pandemic, this global pandemic. You can't take this lightly. You can't take this, as if, okay, it's just a few extra cases of flu.
No, exactly. So like I said, our typical hospitals operate at about 105, 110% capacity. And one of the things that we've done across the country is we've stopped elective surgeries. So if you needed a surgery that was urgent and it was life-saving, you're still going to get that surgery. But for surgeries that people have chosen to have, whether for medical reasons or otherwise, those surgeries are all getting postponed and delayed. And what that's done is that saved about 30% of our beds. And now our capacity, instead of being at 105%, is closer to about 75%. It also means that our capacity in intensive care or critical care units, the ICUs, has now dropped to about 50%. So we're trying to free up those beds.
Sorry to cut you off. Is there any plan, just on this stream of thinking, is there any plan, as they did in China and elsewhere? I think I'm hearing stories now coming out of the US, where they're making makeshift hospitals or constructing centers just to deal with this issue.
That is correct. We are not in the process of constructing facilities, because that will take some time, but we are in the process of repurposing existing locations, expo centers, community halls, gathering locations, public arenas, and using those as not hospitals per se, but using those as assessment and triage centers where you can go and you can get swabbed. Because of course, what we don't want is for someone who is potentially infected or is infected with COVID-19 to come into an emergency room and infect everyone else in that emergency room. We want to keep those sick people separate, which is why we're testing them in other available places.
What's the turnaround time for a test?
If you asked me yesterday, it would have been about 4 days. Currently, it's about 8.
8 days so then a person, and that's usually a person who's symptomatic, correct? That they're going to be testing for, or do you test asymptomatic patients as well?
We're not testing asymptomatic patients. We're looking for people with a recent travel history internationally within the last 2 weeks, people that are symptomatic, and people that are symptomatic in high risk categories.
Is this just due to our limited resources? Because from what I understand, in Korea, they were able to flatten this curve a little bit better because they just started testing everyone in South Korea.
That's right. Yeah. Korea did about 10,000 tests a day, which is an astronomically large number of tests for their population. And they were able to get very accurate numbers for who is infected, isolate those people, and prevent the spread of the virus. One of the issues that we're running into is because Korea was so early, they were able to access and order a lot more of the tests required and the chemicals required for this test without having any shortages. Canada was doing an excellent job and still is. The only problem is because all of the other countries are also requesting for the same types of kits and the same types of chemicals there's now starting to be a shortage of some of those reagents, and that is going to hamper our ability to test everyone, which is why we're not testing all cases, just the highest risk symptomatic cases.
Where are these tests coming out of? Where are they ordering it from?
Typically, it's run through the National Laboratory in Winnipeg, Manitoba, but Health Canada is working to have each local province and jurisdiction get direct access to the supplier. And the supply chains are global, right? So a lot of them were used up in Europe, which we don't have access to anymore. And the other ones, ironically enough, are in Asia, typically in China.
Okay. And so that's where that's where probably the source of these materials for the testing, that's where maybe the holdup is, or the lack of resources.
There's a little bit of a bottleneck for actually ordering these test kits. We do have enough stockpiled for the next about 90 days, but it's beyond those 90 days that we're concerned that we might start to run low on supplies. We won't run out, but we're worried that we might not have enough to meet the capacity as more and more cases are suspected and need testing.